But you have not quoted that, no?
No,
Your peaks are from?
No, there was reference given.
No, it was not there.
Only one.
For each of the peaks
only
you
one
will
photo
take
of
from the
that.
Google, you have to give the www kahan se liya, that you have to mention
only
that.
one photo of glaucoma, that was.
You have to mention that. Okay, ठीक है. In future we will come up with a better this thing. It's a nice.
So I now invite Dr. Aditi Rao, who's going to be presenting on conjunctival closure. A frill in time might save you line. In the meantime, Dr. Himadri can come and sit in the front row, please, if he's there. Go ahead.
Good afternoon, everyone. So our study is based on the conjunctival management in trabeculectomy, and the title of my talk is Conjunctival Closure, a frill in time might save you 9. We have no financial disclosures. So although this is the era of minimally invasive glaucoma surgery, a standard trabeculectomy is still the most widely performed glaucoma surgery as it is inexpensive. It does not require any additional equipment and can achieve good IOP control for all stages and types of glaucomas. But it does have a higher rate of complications, one of which is an early bleb leak, which may lead to a host of problems such as hypotony, blebitis, bleb-related endophthalmitis, etc., which cause scarring of the low bleb and failure of the procedure. The most common conjunctival incision is a fornix-based flap, where the conjunctival incision is made flush to the limbus and the conjunctiva is sutured to the corneoscleral junction. The strength of this technique is that it provides a good posterior flow, but unfortunately the incidence of wound leaks in this technique is 8 to 56%, which is rather high. Another technique is the limbus-based conjunctival flap, where the conjunctiva is sutured about 8 millimeters away from the limbus. This technique has fewer incidents of bleb leaks, but the problem is there is a ring of steel formation which can have a restricted posterior flow. We recommend the frill technique for where the conjunctival incision is made 1 to 1.5 millimeters away from the limbus, leaving a frill of conjunctiva at the limbus. We recommend the closure using a meandering suture technique with the approximation of similar tissues. So here we use a continuous horizontal mattress suture as shown here with a round body needle for closure. Here when we tighten the suture thread, the wound is approximated with slight eversion, possibly causing better healing. So the purpose of our study was to compare the incidence of early bleb leaks following trabeculectomy in eyes which underwent the frill peritomy versus a conventional fornix-based peritomy. And the secondary outcomes were to compare the post-operative IOP at 2 years and also to compare the need of anti-glaucoma medications at 2 years. So this was a retrospective chart review done from 2017 to 2020. We included 160 eyes that underwent primary trabeculectomy with or without a combined phacoemulsification procedure. And patients less than 18 years were excluded from the study, as well as non-standard trabeculectomy such as a limbus-based flap or with MMC injections, or if they were augmented with Ologen. So the baseline demographic and clinical data, the intraoperative data and the post-operative data at 6 weeks, 1 year and 2 years was collected, and a comparison of the two groups was done with t-test and chi-square test. A p-value of less than 0.05 was considered significant. The mean age, the distribution of glaucoma and the pre-operative IOP between the two groups showed no significant difference. But the incidence, when we looked at the incidence of the early bleb leaks, in the frill group we had 2 leaks, both of which resolved with conservative management with a bandage contact lens, and no additional intervention was required. On the other hand, the conventional group showed a significantly higher number of leaks, that was 12.6%. Of these leaks, 5 resolved with a bandage contact lens, 4 needed conjunctival suturing for persisting leaks, and 1 developed a bleb-related endophthalmitis. When we looked at the long-term post-operative IOP control at 2 years between the two groups, there was no significant difference. And also the number of post-operative IOP lowering drops were comparable between the two groups. The Frill technique possibly combines the benefits of both the previous techniques, that is like a limbus space flap. There is suturing of the anatomically similar tissues and lower incidence of the early leaks. And like in the phonic space flap, there's a diffuse bleb and a good IOP control with lower incidence of late bleb failure. The strength of the technique was that there was an inclusion of multiple surgeons, including fellows in training. And there was a good distribution among all types of glaucoma, implying the versatility and the easy technique of this procedure. The limitation was the retrospective design and the post-operative bleb grading, which was variable between surgeons. To conclude, the Frill technique had a lower incidence of early wound leaks when compared to the conventional phonic space peritomy and had good long-term IOP control 2 years post the trabeculectomy. Thank you.
Hello, that is a good study. My concern is that you have compared with the other literatures. What is their results? Because you have shown your results.
Yes.
Have you compared it with the other?
Yes, so ma'am, there was a study published in 2022 by Dr. Vanita Patakre, where she actually used this technique in a twin-site phacotrabeculectomy. And she mentioned that the intraoperative incidence of the wound leaks, like before bandaging the eye, before using a bandage contact lens, was about
Means you
8%.
mean that is the only study you could detect?
There is also
That is the only one study. No other study is available?
for the Frill technique, ma'am, there were 2 studies. One was this one, and there was another one which also used an amniotic membrane graft along with this Frill.
No, that is a different thing.
Yes.
Another thing is that you told that your strength of the study is multiple surgeons.
Yes, ma'am.
But do you think that will be your strength or weakness?
So, ma'am,
If multiple surgeons do it, is it improve your strength or?
So, ma'am, actually, we mean that this technique is easy to learn, and we tested it in various hands. So, it is quite versatile, and we've also included fellows in training. That means that they are not very experienced surgeons, but yet they were able to get good outcomes with this technique.
Okay, thank you.
Thank you, ma'am.
You have to you have to comment on the bias normally. That experienced surgeons, if you have done that, so instead of speaking here, if you put it on the slide, these questions will not come.
Okay, sir. Thank you, sir.
Thank you. Thank you.